Depression is not a serotonin issue. What? Right? That's counter to everything you've ever heard. But I want to show you evidence today that supports that statement, and that evidence is based off quite a bit of research, years of research. And so if you've been in the health space, and it's called the alternative health space because pharma has a monopoly on supposed health that they provide, but in the alternative health space, if you've been in it long enough, you've probably realized that the way that conventional medicine treats psychiatric disorders like depression and anxiety is based off a faulty premise, and that's what I want to dive into today. So depression is not a serotonin issue, and the scientific research does not support the serotonin hypothesis of depression, nor the use of selective serotonin reuptake inhibiting medications, or SSRIs, such as Prozac. And we're going to dive into that. And if you've read my book, The Autoimmune Answer, I talk about that in chapter 4. So let's jump over to the slide, or to the research. So as I mentioned, my book, The Autoimmune Answer, it's available on Amazon if you haven't seen it. But in chapter 4, I talk about brain inflammatory disorders. And in chapter 4, when discussing those disorders, I talk about the monoamine hypothesis, or as a different name for specific to depression, it would be called the serotonin hypothesis. So down here on page 68, it starts, and I talk about how, conventional medicine treats psychiatric disorders via the monoamine hypothesis in general, or depression specifically, they treat via the serotonin hypothesis. And what that hypothesis says is that depression is caused by a lack of serotonin, or an inefficient serotonin signaling neuron to neuron. And so all patients need is the magical selective serotonin reuptake inhibiting drug, and they'll be back to optimal mood, and their depression will be ameliorated. But years of SSRI use has shown that that's not what actually happens in reality, and years of research on the physiologic mechanism of depression, research on tryptophan deficiency, research on SSRI medications suggests that this hypothesis is false. And I talk about that in chapter 4 as well, but I want to show you brand new research from 2022 today that also says the same thing. And then at the end, we'll talk about, well, if that hypothesis is false, then what actually does drive depression and psychiatric disorders. But first, let's get to the hot new study from the journal Molecular Psychiatry, which you can see here as part of the Nature group of scientific journals. And Nature is considered one of the best scientific publication out there, the highest rated, if not the highest, then one of the very highest. So this paper, published this year, 2022, is a systematic review of the serotonin theory of depression. So what these authors want to know is, hey, as they say in the paper here, 80%, you'll see, let me get my pointer here, but it says down here, 80% or more of the general public believe that depression is caused by a quote unquote chemical imbalance. Okay, and that chemical imbalance would be lack of serotonin in the brain. So this is the messaging that pharmaceutical companies have put out for decades, and this is the messaging that the general public believes, and most doctors believe, because most doctors don't read the research. They just take what the pharmaceutical rep is telling them and go from there. So they've managed to dupe 80% or more of the public into thinking that their depression is a chemical imbalance or a lack of serotonin. These authors from Molecular Psychiatry said, well, let's investigate that. Is there any support to that? Because this hypothesis is so influential and making millions to billions of dollars over time for the pharmaceutical companies, but depression hasn't been eliminated. And many people fail even on SSRI medications. So this big long paragraph goes through all the various studies they went over. And what I want you to understand is a systematic review is they're taking tons of studies that fit certain criteria that they're looking for on the topic, and they're going through those to say, did those cumulatively show evidence to support this hypothesis? And their conclusion is that the main areas of serotonin research provide no consistent evidence of there being an association between serotonin and depression, and no support for the hypothesis that depression is caused by lowered serotonin activity or concentrations. Some evidence was consistent with the possibility that long-term antidepressant use reduces serotonin concentration. So there's no evidence supporting SSRI medication for depression. There's no evidence that says that serotonin is even involved in depression from a lowered activity or concentration standpoint. But paradoxically, there is evidence that supports the possibility that long-term antidepressant use would reduce serotonin concentration. So the reason that people take SSRIs, or the reason that they're told they're taking them, is to prevent or to increase serotonin concentration or efficiency. And paradoxically, if they take those meds long term, they're getting the opposite effect. So this is groundbreaking. This should be being screamed from the rooftops by media outlets. But of course, media outlets are owned and supported, brought to you by Pfizer. So you're not going to hear this study talked about out there. So we'll have to look at it ourselves. So let's go look at some of their findings with more detail. So here we are in the discussion of the study. And again, in blue, very important. Quote, our comprehensive review of the major strands of research on serotonin shows there is no convincing evidence that depression is associated with or caused by lower serotonin concentrations or activity. So your head should explode right now, because that has been the mantra you've heard your whole life, or anyone that you know that's been depressed and been put on Prozac or other SSRIs, that's what they've been told. That's the justification they've used to put that person on that medication. So if we continue, most studies found no evidence of reduced serotonin activity in people with depression compared to people without depression. And methods to reduce serotonin availability using tryptophan depletion do not consistently lower mood in volunteers. So tryptophan is the precursor to serotonin. Serotonin's made from tryptophan. Okay, so that's where in my book in chapter 4, I call it the monoamine hypothesis, because the monoamine, tryptophan is the monoamine for serotonin production. Okay, so there's different monoamines for different neurotransmitters. So we need, acetylcholine is the monoamine, choline is the monoamine for acetylcholine. So phenylalanine is the monoamine for dopamine, right? So anyway, high quality, well-powered genetic studies effectively exclude an association between genotypes related to the serotonin system and depression, including the proposed interaction with stress. The general public widely believes that depression has been convincingly demonstrated to be the result of serotonin or other chemical abnormalities, and this belief shapes how people understand their moods, leading to a pessimistic outlook on the outcome of depression and negative expectancies about the possibility of self-regulation of mood. The idea that depression is the result of a chemical imbalance also influences decisions about whether to take or continue antidepressant medication, and may discourage people from discontinuing treatment, potentially leading to lifelong dependence on these drugs. So again, that paragraph is huge, because if the public believes that this hypothesis is right, and they're being told that by the doctors and by the commercials, then they're going to make decisions based on that belief, and that a wrong belief can lead to bad outcomes, right? think of all the different medications and pharmaceuticals put on the market that people were told are helpful, but then later were pulled off the market because they killed people, right? So in the same way, if you are taking something for a reason that you think is real, but it actually doesn't accomplish that, then you're at 100% risk in taking that medication. So we need to get the message out, because if you're taking a drug for a reason that doesn't exist, then the drug can only negatively impact you. We said this a minute ago, but recent studies are consistent with the earlier studies that show little evidence for an effective tryptophan depletion on mood. One study found that antidepressant use was associated with a reduction of serotonin. So again, that's paradoxical. They're taking antidepressants to supposedly improve serotonin efficiency and serotonin concentrations, and the study finds that the antidepressant use did the opposite. Other studies found evidence of 5-HIAA is a metabolite of serotonin, or in the serotonin pathway precursor. Evidence of 5-HIAA levels being reduced after long-term antidepressant treatment. So again, taking the drug actually lowers the level of the thing you're trying to raise. These findings suggest that in the long term, antidepressants might produce compensatory changes that are opposite to their acute effects. And in conclusion, in the blue, this review suggests that the huge research effort based on the serotonin hypothesis has not produced convincing evidence of a biochemical basis to depression. We suggest that it's time to acknowledge that the serotonin theory of depression is not empirically substantiated. It's not supported by the science. So if chemical imbalance is not the cause of depression, then what is? That's what we have to ask. And in my book, I talk about neuroinflammation as the basis of depression and psychiatric disorders. And that's the premise of chapter 4. And then chapter 5, the whole book talks about different things that can contribute, but neuroinflammation is the underlying cause. If you're inflamed, you're going to, and that inflammation drives brain inflammation, then that can drive depression. And there's plenty of research to support that. And one major area what's one area in your body, if it's inflamed, that can lead to body inflammation, then brain inflammation? The gut. So then we have gut-brain axis connections that can drive depression or drive anxiety. So here's a study from 2021 entitled Gut Permeability and Cognitive Decline. And in this paper, the authors conclude that data support the hypothesis that gut dysbiosis leads to systemic and brain inflammation and subsequently cognitive decline. So they were looking at cognitive decline and dementia and how, gut bugs and gut issues can lead to body inflammation, brain inflammation, and ultimately contribute to the cognitive decline. But it can also drive inflammation that drives depression or drives anxiety or drives OCD or drives PANDAS, or depends on your unique psychiatric disorder. But the biological plausibility is supported big time. Here's a study showing that sleep dysfunction, if you have sleep issues, that can drive depression, that can drive anxiety, that can drive cognitive decline. So this study is showing that, again, if we destroy the gut microbiome by chronic antibiotic treatment, that can alter sleep, and altered sleep alters cognition. And if you try and, if you've ever been sleep deprived, you know that you're not cognitively sharp. And if you have persistent sleep deprivation, that can drive mood and cognitive issues. And so, that's a sleep mechanism, but this study is talking about a sleep mechanism that's caused by a gut mechanism that's caused by antibiotics. So antibiotic treatment chronically could result in depression, through these mechanisms if we can follow the path. And then there's studies looking at, well, what if we improve the gut environment, using prebiotics and probiotics in adults with depression or anxiety. So this study was in the British Medical Journal of Nutrition, Prevention, and Health, called Food and Mood, and they're looking at prebiotics and probiotics as natural interventions. And the first line says, a bidirectional relationship exists between the brain and the GI tract, right? And we've talked about this many times. It's called the gut-brain axis. So if you impact the gut negatively, that can impact the brain negatively. If you impact the brain negatively, that can impact your gut negatively, right? So, we've talked about multiple ways gut issues could drive brain inflammation here. Well, if you sustain a head injury or concussion and brain inflammation starts first, that can lead to gut issues. Okay, and IBS is a classic example of a gut-brain axis or brain-gut axis disorder, where if you have IBS and if you have IBS-D, which is diarrhea, IBS with diarrhea or constipation, you might realize that when you're more stressed, you have more diarrhea or more constipation, depending on which one you have. So that's an example of a brain to gut side of a brain gut brain loop issue. So this study found that in the studies that they identified looking at prebiotics and probiotic use in depression, anxiety in adults, all demonstrated significant improvements in one or more of the outcomes measuring the effect of taking the pre or probiotics compared to treatment or placebo. And they also help things outside of depression, anxiety, is what the discussion piece is saying here. It said patients with certain comorbidities such as IBS might experience greater benefits from such treatments, given that they're useful in other conditions besides just depression and anxiety. So the takeaway here is that there's many potential causes of brain inflammation, and the inflammation of the brain is the underlying promoter of the depression. And it is possible, and I mentioned this in my book, that it is possible that brain inflammation, if it's consistent and persistent and chronic enough, that could lead to a monoamine deficit or a serotonin deficiency in this case over time, because if your brain's inflamed, you're metabolizing through your serotonin or your dopamine or whatever raw materials we're talking about, you're metabolizing through those faster because you still have to have the physiology you need to function. And so the more inflamed you are, the faster you can burn through those. Well, if you have that inflammation chronically, you may ultimately end up with, say, a serotonin deficiency, but that was secondary to the brain inflammation and whatever caused that, right? So the cause isn't the serotonin deficiency. The serotonin deficiency was caused by the cause, which is whatever is driving that brain inflammation in that given case. So I hope this was enlightening for you, and I hope it causes you to question, what in your life, if you're someone out there with depression, I hope it causes you to question what is causing your depression. Okay, if it's not serotonin deficiency, then what is it? What in your life and or lifestyle, what factors, because there's probably an S at the end of that word, what factors are promoting brain inflammation? What factors are promoting maybe gut inflammation or body inflammation that could result in brain inflammation and depression? And if you're on an SSRI, you have to question, well, if this thing isn't doing anything for me, should I take it, and how do I come off appropriately? And you should not stop cold turkey, because you can have withdrawal symptoms and other side effects, especially if you've been on SSRIs for a long time. So the proper choice is not to quit cold turkey. The proper choice is to have a conversation with your prescriber and work with them to see, can you come off completely, or can you lower it to the lowest dose possible? Because there are such side effects as what's called serotonin syndrome or the ZAPs or things like this. So work with your prescriber to come off appropriately. Do not stop by yourself. But take a self-inventory. Hey, where in my life could I do better? Is my diet inflammatory? Is my physical inactivity causing me to be inflamed? Do I have sleep issues? Am I in a relationship or a job or a financial situation or something that's overly stressful? How can I take steps each day to get 1% better in these areas, to lower that inflammation and lower the contribution to my depression? And who could I work with to help me accomplish that goal?